help you along the way to have a clear understanding of that. Again, we're dealing with the cardio section, and when we were reviewing our ICD-9, remember our hypertension and our heart diseases and our myocardial infarctions, our heart attacks, and our MIs had a lot of bearing on our coding. And there's a lot of guidelines in your ICD-9 book for it, and it's a real good review again of all that information we went over. The surgery section, your CPT coding, 139, page 139, it shows you, it starts off by telling you that the surgical procedures, again, just like respiratory, the surgical you will find in the section we're fixing to review, but there's a lot of procedures that are performed that are cardio related, just like respiratory, that you'll find in the medicine section. It tells you that on the first paragraph. And then surgery codes 33010 through 33999, that's your cardio. Pacemaker or pacing cardioverter defibrillator. It gives you the code series there for these and gives you a general description of what these all entail. 33202 is for the insertion of the device. 33218 is for repair. And it tells you there you will need to know the type of system in order to be able to code the insertion, repair, or removal thereof. And it gives you a brief background on each type of system and what they are all about. And for example, the cardio defibrillator delivers electrical shocks and sometimes paces the heart. Sometimes separate codes are reported with this system in addition to, such as a revision or relocation of a skin pocket for a pacemaker or skin pocket for a defibrillator. These are things that you don't always think about. You think they're bundled into the main procedure, but when it comes to these devices, they're a little bit more peculiar. Again, your section guidelines always direct you of what it includes and what it does not include, and whether or not you need to add on codes or what have you. There are different codes if the system is a single or a dual chamber for pacemakers. And it gives you the codes there. Dual chamber pacemaker system placements 33208, and then 33206 and 07 are for single chambers. If only the generator is inserted, you look at codes 33212 and 33213. And again, if you have no idea what I'm talking about, you really need to read the first few pages of this and this section right here, because it goes into pretty good detail of what a pacemaker and defibrillator do and why they're inserted. It tells you the codes in this section are used a la carte. More than one code is usually required to describe the full procedure because they're so different. You can have 3 or 4 different types of code reporting for the basic same procedures, but there's technicality differences in those systems that will require a different code series to be reported. The last few sentences, it tells you if a new system is placed after removal of an old system, for instance, code the removal of the parts and then the insertion of the new system, and it has the removal there. A lot of times you won't have to do that, like a removal of a stent and placement of another one, because they're already there and you're doing it and it's kind of included. They don't ever, but when it comes to pacemakers and defibrillators, they are quirky, to say the least. But again, your section notes will direct you to those codes if that was in fact the case. The cardiac valve procedures 33400 through 478. It goes into a little bit of it tells you a lot about that, but the main thing about this is the T codes. The second paragraph there, codes 0256T through 0259T report the implantation of a catheter delivered prosthetic heart valve. And again, it should direct you there. If we come across one that's not, we'll go in further, but everything should be straightforward. Percutaneous valvoplasty of the mitral valve is reported with a 9000 series code, not one out of the the 3. The same procedure for the pulmonary valve is reported 92990. It's just, again, you're going to see a lot of cross-reference to the medicine section in the cardio chapter. Your CABG, your coronary artery bypass grafts, they're just as peculiar as anything else in this section, and they are the code selection will be driven based upon the terms of the procedure. Everything is kind of like the fracture care. You hang on it on every word to determine the correct code selection. CPT divides codes by venous, arterial, and combination arterial venous. If only venous grafting is performed, it gives you the codes that are applicable. If arterial grafting is performed, it gives you those codes. If both are performed, that's series codes. It says, for example, CPT code 33512 describes of 3 venous CABG, and CPT code 33534 describes a 2 arterial graft CABG. You must know which arteries and veins were procured for the grafts. Some procurements are reported separately and some are bundled. According to CPT, procurement of most arteries in the saphenous vein is bundled into the code set. Harvesting may be reported separately for the following, and it shows you down below which veins or arteries those are. Again, this will be in your section notes, and it'll tell you whether or not these are included or bundled. How the vein was harvested is also important. And I may be talking and making no sense to you if you don't understand what a CABG is. All of this information is here. It tells you that a CABG is performed to bypass blockages in the coronary arteries to improve blood flow. Arterial or venous grafts are harvested from the patients to be used as conduits to the coronary arteries. And then if you refer back to that, the second set of bullets on the right-hand page of 140, remember when we were coding CAD, coronary arteriosclerosis, when we are doing our ICD-9, 414.00301 and 414.04, those code selections is based upon the nature of the grafts that are used, if a bypass graft is present, and whether or not it's a native artery or what have you. So they go hand in hand. The add-on code 33530 should be coded for additional reimbursement for reoperation CABG or valve procedures performed more than 1 month after the original procedure. And again, that will be in your section guidelines. Do not use HCPCS level 2 coronary artery modifiers, LC, LD, RC. When we went over our modifiers, we kind of hit base at left coronary, left, left coronary, left LD, left dominant, right coronary, to identify the bypass graft placement. Those modifiers are used to indicate the specific vessel involved in the percutaneous coronary artery procedures, 92980 through 92996. And those are actually your caps. Our caps, I don't know if they were, no, they've always been in this section. But a few years ago, all of these cap codes were changed. 92980 and 81, those are for the placement of it. A lot of times you have coronary, with stent placement. A lot of times you'll have coronary catheterization without placement of stents or balloon dilations, and you won't use those codes, but when you do, it's telling you that that's when you would utilize those modifiers. It goes on about your transluminal angioplasty in that code series. Gives you a brief overview. Your bypass graft codes. Your central venous access codes. It's important to understand that with your central venous access procedures, it tells you that there are 5 code categories: insertions, repairs, partial replacements, complete replacements, and removals. The devices may be inserted centrally or peripherally. Central insertion is into the jugular, subclavian, or femoral veins. Peripheral insertion is into the basilic, cephalic, and other peripheral vein. Look at page, I'm looking for the anatomy of the veins. That always helps me. See, we're on page 22, 21 and 22. All right, central veins, or central insertion, jugular. If you're looking on page 22, or jugular, you see, for those of you who don't know, that's in your neck. Your subclavian, where's that one at?
That's
Right here? Where's, is it? Okay, on page 21, you see that one, right there on your clavicle. And then the femoral, it's your leg. Now, if it's peripheral, basilic, cephalic, it would be on page 22. Where's the thing it doesn't specifically have a, it's got to, hold on a second, I'm sorry. Two yard another book. Okay, if you look in your CPT book, there's an appendix that is GH. All right, on appendix J. It's when you're dealing with the cardio. Appendix J is one that I utilize a lot, but we'll get in that in a minute. I'm sorry, I was trying to find something else, you know, maybe I'll have it in a minute in regards to central versus peripheral. But the devices may be toned or non-toned. Toned, it may be accessed via an exposed catheter or a sub-Q port or pump. And all of that, it will make or break your code selection. Your devices will actually be coded in addition to, and it's the same with your pacemakers. They may not ask you to report them in scenarios, but on the outside world, if your physician or your hospital is paying for that device, then you will code a C code from your HCPCS book, I think, you know, HCPCS book, to capture the reimbursement back for that supply. Your interventional procedures is used to diagnose and or treat diseases using minimally invasive techniques such as fluoroscopy, ultrasound. You'll find most of these in your 9,000 medicine section. Your vascular injection procedures, 36,000 through 36598. These are all necessary local anesthesia, introduction of contrast media with or without automatic power injection, and or necessary pre and post injection care specifically related to the injection procedure not included. What all of that just meant is that the procedures, if you look at the procedures under vascular injection procedures, they're usually a saline lock. They're usually a lab draw. They're usually bundled with other services with greater procedures. For instance, if I go in and I have an infusion an IV infusion of antibiotics, they're not going to code for the infusion and the saline lock. They're not going to code for both this bundle. You can't have an infusion without having saline lock, of course, unless it's some other, but there's really no way. Okay, y'all get that? It's bundle. There's, again, if it's a procedure that an infusion cannot be performed without an infusion, so of course they're going to bundle that service and the payment thereof into the major procedure. Blood draws. If they perform an infusion and they get a blood sample from that, what is it? The headlock. That is not separately reported. However, if they set a saline lock and then they come in and take a blood draw, there are certain circumstances you can without an infusion. But for instance, let's say that I come in and they place an IV in my right and they do my infusion, but then they come back and put a saline lock and come and do a blood draw from the left, and there's not infusion. In those instances, you can. It's a different location. It's just important to understand that those vascular injection procedures are those that are separately reported, that they're not bundled in with the greater procedure. Additional second and or third order arterial catheterization within vascular family of arteries or veins supplied by a single first order are expressed with certain codes. All of that is why I don't like cardio, and that's why I utilize this. If you look at that table, it tells you the first order, second order branch, third order branch, and beyond. Because I can't remember all that. Hell, I can't even remember where half my veins are. So if you utilize this table that they have in the CPT book, and they have a table like this in the AMA book, it'll get you where you need to go and when you're deciding what type of procedures to be coding. This is very important stuff to read over. The additional first order or higher catheterization in vascular family supplied by a first order vessel different from a previously selected and coded family or coded separately. All of that's a lot of information, but if you read all of this, you'll get it. To code for an interventional radiology procedure such as a cardiac cath, the number of catheter access sites is needed, and you need to know that. The number of catheter endpoints. It'll tell you how many vascular families and how many vessel orders were assessed. Most of these are peripherals. The number of vessels visualized. This will tell you how many radiology supervision and chart codes you may need. It's a step-by-step process when you're coding for cardio and interventional RADs. It goes into further detail about your appendix L and your vascular family order. It tells you, think of the vessel order like highways off of ramps. The main trunk, the non-selective veins or vessels, is the main highway. And if you take a ramp and off that, you have all these little highways to turn on the main highway, and so on and so on. That's where you get your first, second, third, and so on orders. When you get off the main highway the next time you have taken another turn, you always drive back the same way you came. It's the same with when you put that needle and catheter in, they come back out the same way. The appendix, it's J for us, it's L in the AMA. But the appendix makes the assumption that the starting point is catheterization from the aorta. If the starting point is different, the orders may be different, so you have to keep that in mind. There's an example here, part 1 is surgical, and this is a little over most of our heads. I hate this section, but we're going to review it anyway. In the hospital, a catheter was placed in the aortic arch and right and left common carotid with imaging performed in all of these locations from a right femoral artery puncture access. The aorta is the main trunk. And let's see if we can find a diagram to help y'all navigate this without too much confusion. What did I say earlier? 22, 23. Yeah, if you look at 21, you see where the aorta is. And in this case, that's where they were, let's see, placed in the aortic arch. So it's actually a little bit further up the arch of aorta, chest area. That's where it was placed. And the right and left common carotid. The right common carotid and the left common carotid. You see it's next. So in layman's terms, they placed the needle in that aortic arch and then fed it through to the right and left common carotids. They do this a lot of times checking for blockages, and what they have to use is the imaging, is fluoroscopy or ultrasound, and sometimes it's included with the procedure codes and sometimes it's not. You just have to read the procedure codes to determine that. It says imaging performed in all of those locations from a right femoral artery puncture access. Well, that's where they have to have another access site for that. The femoral is in the leg. You see? All right. So the aorta is the main trunk. CPT Appendix L, or J in our case, defines the right common carotid as a second order vessel. You see right there the first order in the right common carotid. From the inside, start there always, and then if not, move your way down. But it's just the family. And you'll see the left common carotid as a first order vessel off of the left common carotid family. Do y'all see that? Mm-hmm. There are two different vascular families accessed in this example. We will code the highest order access first. This is the right common carotid as a second order vessel. Y'all see that? It's a lot of information to, I promise no other chapter is like this. Report 36216 for the initial second order vessel. The innominate had to be passed through to get to the right common carotid and is included bundled into 36216. You determine that by the graph, or that's how I do it. If you're skilled enough to know those branches, good for you, but I always go by this graph. The left common carotid is the first order vessel, because it is a separate family from the innominate. It can be coded in addition to the right common carotid. The code for the left common carotid is 36215. Do y'all see the left common under it? Let's start from the beginning. We've got, again, you've got your vascular families graph here. It was placed in the aortic arch in right and left common carotid. So we're looking for the right and the left common carotid. You see the right up at the top. You see the left down at the bottom. Y'all see them both? Okay. So we've got a second order and a first order branch. Okay? Now, that's what they're saying. There are two different vascular families accessed in this example. You see? Those are two families, two family trees on this graph. And that's why you would report both of those codes. The 36216 will be reported for the initial second order branch, or the right common carotid. See, it was our second order branch. And then the 36215 is for our left common carotid. The complete coding for the surgical portion of this case is 36216 right for the right common carotid and 36215-59-LT for the left common carotid. The modifier 59 is appended to show that we access a different family and we are not unbundling the first and second order vessels from one another. Yeah, I don't like this section at all.
Me neither.
But if you just know what to look for, there will, don't confuse yourself. This is, again, study these. The vascular procedures, the radiology, it goes into a little bit more information about that. Your supervision and intart, you're going to utilize modifier 26 and TC a lot in this section for your professional and technical components. There's a lot of different types of radiology that's utilized, whether it's fluoroscopy or ultrasound. There's a few others that I can't think of off the top of my head, but it goes on a little bit more to tell you about that and how it feeds into the cardio section because it's utilized a lot. Again, your section notes will tell you whether or not you need to utilize them. It tells you a testing technique. Make an entry in your CPT index for aortic arch imaging and list code 75650 next to it. I don't know why. I think it'll tell you why, but those testing techniques they're giving you tidbits. They're getting you ready. Pay attention to those. Endovascular revascularization. Arthrectomy is a procedure used to remove plaque from arteries. It involves using a cath with a cutting device into a narrow blood vessel to enlarge the lumen by mechanical removal of the intima and the plaque. Arthrectomy as well as angioplasty and stent procedures of the lower extremities are reported with codes 3722 through 37235. Carefully read the notes for endovascular revascularization. This code in this section includes the work of assessing and selectively catheterization of the vessel transversing the lesion, radiology, supervision, and intart directly related to the interventions performed, embolic protection of use, closure, blah, blah, blah. When they use the term lesions in cardio section, they're referred to blockages or buildups. It's not an actual lesion. It goes on to tell you about some of the heart and cardio system radiology sections, section code series, the CTs and the specs and all that good stuff. Just read over that a little bit. And then the medicine again, the medicine section and the radiology section is utilized a lot for cardio. Cardiography down on page 145. Your EKGs, they're in your medicine section. And then your implantable and wearable cardiac device evaluations, those are your event monitors. They're an outpatient thing. You're having palpitations, you go in and they fit you with the, can't remember what they call them. Holter monitors. And there's different kinds as well, but they're all, you would think cardio nature, but they're not invasive. They're not excisional. They are in the medicine section. Your echocardiography, TEEs and TTEs, transthoracic and transesophageal. There's differences, but whether or not they're Doppler or M-mode or what have you, spectral or whatever, there's different codes to determine that whether or not you're following up on a congenital anomaly. But you would think that the echocardiography would be in the radiology section, but it's in fact in the medicine section. And then your cardiac catheterizations. It's important to understand it, because if you don't, it's going to intimidate you to the point where you're just trying to pass the test and say screw it. But if you can really understand the cardiac caths is easy. I don't like the peripherals. These are your vascular peripherals. I hate those. But the cardiac caths are easy, and always. Any employee or employer I've ever had, your cardiac cath coders are highly sought after. And then you've got your electrophysiology, your procedures such as stress tests, they're treadmills, things of that nature. Again, a lot of 26 and TC modifiers, professional and technical components, when they're documented as such. Modifiers, it goes over all that good stuff again. PICS level 2 codes gives you a pretty good briefing on that. This GO278 is utilized by Medicare for cats. They will not pay for the iliac or femoral artery angiography without that G code. There's good glossary for selective catheterization. All of these words I'm throwing at you that you're like, huh, is all there. There's your glossary. And then our chapter review. And we're going to hit some of these because y'all are going to hate me. All right. Let's look at number 5. Well, let's look at number 4. Let's start off with this one. 69-year-old white female with 10-year status post 3-chamber pacemaker where the generator is at its end of life. The pacemaker generator is explanted and the leads are then attached to the new generator. What's the CPG code for this encounter? If you go to pacemaker, and then removal, and then pulse generator, pacemaker. It leads you to 33233. When you look at 33233 in the book, it's a revised code. It tells you that this is the removal of permanent pacemaker pulse generator only, that it excludes the removal and replacement of the pacemaker pulse generator and transverse electrodes. So if you go over to the codes that they refer you to, 33206, insertion of new or replacement of permanent pacemaker with transverse electrodes, atrial. Well, that's not what they did though. They just did the generator.
What did it be? 33213? Alright.
The answer, I think the answer is.
33288.
Yep.
228. Do y'all see why we didn't go over to the 33206 and 33208? No? When we went to 33233, it says it excludes removal and replacement of the pacemaker pulse generator and transverse electrodes. Code 33233 with 33206 through 33208 and blah, 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 blah. So then if you went over to 33206, you'll see that is an insertion of new or replacement of the pacemaker itself, not the generator. That's the whole shebang there. So we knew that was just wrong. So that's going to cancel out that whole statement. And then 33234, you'll see insertion of pacing electrode. That has nothing to do with the replacement of the generator. That's just the electrode. 33208 sorry, 33234, 33235, again, that has nothing to do with the generator. And when those, but then when you go down from 33233, you'll see removal of permanent pacemaker pulse generator with replacement of pacemaker pulse generator single lead system, and then 33228, the dual lead system.
So why was the 33212 not, or 213?
33213.
It's insertion of pacemaker,
Yeah, that's
not replacement.
right. That's not the replacement, the removal, and
Gotcha.
that's what's so tricky about these. Not only do you have to keep in mind whether or not it's an insertion or removal replacement, you have to remember if it's dual or single chamber, how many electrodes, whether it's the generator itself or the pacemaker device, or just the electrodes. There's so many different components that go into them. And then again, the skin pocket, that sometimes they have a skin pocket that's already been formed, and sometimes they don't. So the formation may not be included. That's why when you look at those excludes, always review them to make sure that that section takes the longest time. Look at number 5. A 38-year-old's blood pressure was progressively trending downward, and it was determined that an emergent central venous access was needed for fluid resuscitation. A non-tunnel catheter is what you're going to need to know. Your central venous access non-tunnel catheter was used to access the subclavian vein, you need to know that, and secured into place to infuse medication. Due to the patient's low blood pressure and anticipated need for vasopressor agents, a radial arterial line was also desired. So you need to have that. The left radial artery pulse was easily palpable. The skin was punctured by needle, and the angiocatheter was placed in the left wrist. All right. Your central venous access, you'll be able to look it up just as that. I do believe central venous access. Yeah. If you have a central venous catheter, we're doing an insertion. Central 36555 through 36558. Okay, and then when you get to 36555, these access codes they're usually divided or different based upon age, because there's a lot more involved with a child or a baby, 5 years younger or 12 months younger, so forth. So 36555 is younger than 5 years of age. How old is this person?
38.
38. All right, 36556 is 5 years older. Again, this is insertion of a non-tunnel centrally inserted device. This one is a non-tunnel catheter, central venous access. Insertion of the instrument without insert a central venous catheter. 36558, 36555. All right, the difference in 36555 and 36557 is one is non-tunnel and tunnel. So we know 36556 is the correct code. All right, and then our radial arterial line, that angiocatheter was placed. I don't know if you can look it up by catheter or angiocatheter. Let's see here. Not by angiocatheter. So catheterization Central 3655, 3656. You just go to arterial or so we get to it from here.
Well, it's a percutaneous vessel, isn't
Did you go to, what did you
it?
say?
I did catheterization, arterial,
Uh,
and then perc. And that,
percutaneous?
yeah.
Yeah.
Because it's
There's
radial.
no other way, I don't see any other way to get to it other than that, on that from catheterization. If you go to artery, radial, artery. You idiot. I heard that. Did you hear me?
Alright.
You idiot.
Yeah.
That's the only way I could see to get to it. But again, it's kind of like the skin section. If you know the cardio section, because it's divided,
Yeah.
the access system, the devices, and the injection codes, where are they at? The 36,000 is where the injection codes start. It's kind of like I just always, I know which area of the book to look in. I know that doesn't help you guys when you're learning, but
That's how it tells you in the back to look it up. Catheterization,
That's it.
arterial, and percutaneous. Yeah.
yeah, that's the only way I could figure it out too. But it's hard for you guys to know that, I guess, to think percutaneous.
Well, if
when
you
you're
see
looking
needle
for this.
puncture,
Right.
that's gonna.
But you know the keywords that they're looking for.
Yeah.
You know.
Yeah. Punctured by a needle. Just remember that means percutaneous.
So it would have directed you to 36620,
Mm-hmm.
and if you go there, arterial catheterization or cannulation for sampling, monitoring, or transfusion, percutaneous. Just hope that when you get in situations like these where you're kind of unsure, it'll be a multiple code selection per answer, and you can narrow it down. That's what I did when I wasn't so sure. I knew it had to be C, not because I knew about that procedure, but because that one was right, you know? It's 9 o'clock, y'all, and I feel like we didn't get anything done.
Yeah, we did.
There's a lot in that cardio though.
There is.
But y'all look at, if y'all can do 9 and 10 for sure, some operative reports, in the digestive system too, because we're gonna fly through digestive. Monday, we're gonna go back over the cardio and finish up. If y'all can do those operative reports, that'd be great. We're gonna review that, and then we're gonna fly through the GI system and the urinary and male genital system.
When should we take the second practice test? Should we wait a while? Yeah.
Yeah, let's, well, you know what? We are already adjusted to that. No. Kathy, you can go ahead and take it.
Okay.
Because you've already done this. I think you're gonna do fine. As a matter of fact, I think you're gonna be even more surprised with where you're at than I think you're just that comfortable with that when you go there, you'll be fine. But for everyone else, let's wait until we, finish the chapter. What's gonna happen is, y'all gonna have to take